So thank you all for coming. My name's Marc Moisi. There are some familiar faces and some new faces, so I really appreciate you all taking the time. And my goal here is to introduce everyone here to some new concepts, but at the same time, I want this to be open and interactive. So feel free to interrupt me at any point. If there's something that's too complex or over your head, please just ask me to clarify it, because I'm really here for everyone here to help understand where to go next. So my name's Marc Moisi. I'm the director of neurosurgery and spine at Hurley Medical Center. And as you guys know, we have the flagship. We've taken off with the Hurley Neurological Center, which is now the Mid-Michigan Center for Brain and Spine Disorders. I'm surrounded by some of my colleagues here. In the back, we have my partner, Dr. Bowers. He is one of our frailty experts, probably one of the most well-published frailty experts in the world, publishing over 40 papers a year. I'm also surrounded by my staff, Miss Brenda on the right. We like the name Brenda, so we have another Miss Brenda over there. And Courtney, and our service line, John Stewart. Over here on my right is Peter. He is one of our nurse practitioners and the lead nurse practitioner that some of you guys may recognize. And of course, our lovely colleagues here who are trying to get my good side, not my bad side. So if I turn, he might be getting my bad side. So let's begin. So obviously, we kind of talked briefly. I'm a fellowship trained spine surgeon. Obviously, I'm a neurosurgeon. I take care of all parts of the brain and the spine. But through my training, I really grown to love complex and minimally invasive spine. I have a family that are all engineers, so I'm actually the black sheep of the family that went into spine. But I try to convince my dad, who's a structural engineer, that the spine is kind of like the structural engineering of the human body. He still told me I can't show up to Thanksgiving dinner, but that's okay. So where are we here? So back in neck pain, if I ask anyone here, and obviously this is a very selected group because otherwise you wouldn't be here, but at one point or another, 80% of people will be having some sort of back or neck pain. I'm actually going to say 100% of us will have it at some point during our lifetime. And why is that? We live on Earth, and what does Earth have? It's got gravity. And with gravity, we're always battling it. And the one negative thing about gravity, other than keep us grounded, is that it never gives up, and eventually our bodies do. But at the same time, we were gifted with our joints. And this is why, this is a new understanding and why I'm going to try to open some people's eyes to see, are you a candidate for this? And what do we do? So obviously the degree of pain will differ, but why do we have back pain? I'm surrounded by another colleague, Dr. Elganani here, who's a chiropractor, who we work very closely with. And, together we create a multidisciplinary team. So I'm sorry if I'm simplifying these things, but every one of us comes from different orders of life and different understandings, so I'm going to go to the basics. So we obviously have our head, right, in the brain, and that is kind of the control center. And then you have the different parts of the spine. And I'm not going to bore you with the different Lego pieces and how many levels are at each one. But you do have your neck, which is the cervical. And the neck is a very important part, right? Because what does it do? It holds up our head, which is the information center. But our heads are very heavy, and our neck muscles are quite weaker than they should be holding up such a big, a heavy object, right? Then the thoracic spine in the middle is supported by our rib cage. So you've now got the thoracic spine that's already being supported, and then you have the neck up there, the cervical spine, kind of all of it on its own. And then as you go under the thoracic, you go in the lumbar, and this is where our back pain comes from, right? And again, it's not being supported by anything, and it's tasked with the opportunity to take care of the rest of the body. Make sense? And then at the bottom, you've got the sacrum and the coccyx. That's also very important, but most people won't come in, I'm not saying they don't, but most people won't come in just with sacral or coccygeal pain. So again, to simplify things, as we talked in the previous, you all hear the vertebrae, right? What are the vertebrae? So the vertebrae are each segmented level of bone. And they're each of them are surrounded by discs. And when you hear disc herniations, these are the discs that people talk of. And these discs are kind of the cushioning. So when we jump, when we do anything, you know, when you're playing sports, when you're jumping, when you're walking, it does the cushioning for the body. And it cushions the nerves. And sometimes we may do something, you know, that's detrimental, and you may get a little bit of squeezing of that disc or a herniation, okay? What I describe to patients when you have a disc herniation, if you look at the disc itself, if it's a jelly donut, sometimes you get a little bit of that jelly donut that comes out, and at times it causes problems. The caveat to that is just because you have a disc herniation, that does not mean you need to have surgery right away. And as we're going to talk about here in a second, let me just kind of finish. So the cage itself of the bone, what does the bone do? It protects the most important things. That's our spinal cord. Just like the skull protects our brain, which is the nervous system, the spine itself, what does it do? The bony part of it protects the spine and the nerves, or the neural tissue. And this is what's important to understand, that this is all a cage, but sometimes the cage fails. And this is when the cage fails, this is when you may come to see someone like myself or one of my colleagues. But what we believe here at the Neurosurgical Center in Michigan, at Hurley, is that we believe in the multidisciplinary approach. And who should be involved? Number 1, 2, 3, 4, 5 are the patients and their families, right? Those are the most important, because we're all here for you, right? We are your team members, and the most important part and the captain of these teams are the patient themselves with the close assistant managers that are their family members, right? They're your advocates. Obviously, most patients don't come directly to a neurosurgeon or a surgeon or even physical therapy. They go to their internists, right? So they're kind of the second line. They're kind of your quarterbacks, so to speak. With them, we work together to devise the best plan for you. We'll include your pain specialists. Obviously, without a radiologist and us understanding what's going on in your scan and getting an MRI or the appropriate scans, we don't know what's going on. Our case managers, our social workers, our PMNR, everyone in this is part of this team. And what we believe in is a multidisciplinary, patient-centric team, which means the patient is in the center, and we're all surrounded by, for the patient, because every patient is different. It's individualized care. And today, that is kind of the key term for everyone, right? It's individualized care, because what may bother patient X may not bother patient Y, and the source or the treatment process may not be the same. So that's why it's very important as specialists to understand all the different ways to provide that care for each individual patient. So this was one of my kids' favorite from Halloween, and they kind of make me insert it in most of my cases, but you know. So let's talk about the cervical spine, okay? So we discussed it, right? It's holding up our head, and it is probably one of the most important parts of your body. You know, Dr. Bowers may argue that it's the brain, but you know, as a spine guy, we may have a little discussion later, but you know. But nevertheless, right, it does hold up the brain, does hold up the skull, and there's a lot of stress on it. What does it do? Well, what's the first thing it does? It could let you say no or yes by its individual joints, right? And it's a different structure than the majority of the rest of the spine. The first vertebrae, and the second one doesn't even have a disc. It's held together by ligaments. But then when you move below C2, which is the second vertebrae, you've got its normal structures with the disc, with the bone, and this is kind of where this whole motion preservation comes into play. So you are able, with a normal spine, to move about freely and bend, okay? We discussed that there's 7 vertebrae, and each come with its adjacent nerves. And when each of these vertebrae has a nerve that comes out, that is the nerve that goes to your arms. It could create pain, discomfort, numbness. Some of that could happen with turning the head in one direction or the other, or bending, or looking down. And each of these vertebrae have a hole, and they're called foramen, right? So when you hear stenosis, which means narrowing, and if you look at if a patient gets a scan and you look at that scan and you look at, what's the first thing you do? You read the report that's on my chart and you go to Dr. Google before you even see any of us, right? And you're going to see stenosis, foraminal stenosis, central stenosis, maybe yes, maybe no. So the foramen is where the nerves come out at each level, and each nerve is numbered, and each numbered nerve goes to a particular part of the body or muscle and does its appropriate structure or function, okay? And like we discussed, each of these discs, each of these vertebrae are split up by discs, and they come with 2 numbers. So when we say C3-4, it's the C3 vertebrae and the C4 with its disc in the middle. Okay, does that make sense so far? So this is kind of the natural motion of the spine with that little picture on the right. Okay, and there are many different ways to move the neck. Obviously there's the front back, which is called flexion extension. You move it side to side. And the joints want to be able to do what they normally want to do, move in their appropriate directions. And us as human beings, we want to do that with no pain and no discomfort. So sometimes when there's contact with these bones, it does create what we will call arthritis or pain. And this is when you say, hey, your body warns you, it's like, hey, I may need to do something about this, right? So we talked about flexion extension, which is yes, no. You can move side to side. You can move around an axis, not 360 degrees, okay? If anyone tells you you can, I would caution you. And that's kind of where we want to keep it, right? We were given certain motions and mobilities, and you want to keep your body to be able to do that motion preservation. So what is causing your arm pain? Well, there's a genetic predisposition. There is some loose research that does show that there is a small predisposition towards females, but there is also a predisposition within the family. But there isn't kind of a direct. Just because your parents had it doesn't mean you necessarily had it. It's not like, some obvious, if you have blue eyes, you may have blue eyes. There's kind of mixed into our genome that may happen. But, a lot of you in here probably have heard degenerative disc disease, right? And it's on every single scan. And I have a big problem with that. Degenerative disc disease is not a disease. It's the wrinkles and gray hairs of the spine, right? We live on Earth, and like we just started this conversation, what happens? Well, as you cushion by walking and with gravity, there might be some compression. So just because you have some arthritic changes or some degenerative changes, it's still not a disease. A disease process is more simply a diabetic where you have some medications. The problem is when you start calling degenerative disc disease, what's going to happen? Someone's going to want to operate to cure your disease. And that doesn't mean that's necessarily the next step. Okay? We are exceptionally conservative at Hurley, where we operate on less than 10% of our patients. Okay? The reason we have good results is because we take that conservative measures. When a patient walks into my clinic, my first thought is how could I get them to a point where they could enjoy their normal life with no operation, okay? Which is a reverse pyramid as most surgeons. And we hear that a lot. And that's why we get a lot of second, third, fourth opinions, and that's why we do a lot of revision work here. That's not to say that that's the right step for everyone, but that should be in the forefront on how to approach an entity. Of course, there are emergencies and there are more critical symptoms that I kind of put an asterisk next to that sometimes you don't have a choice when there is a surgical emergency or some other process. But how do we figure this out? And we kind of started at the beginning. We said, hey, you know, you're going to come see your internist. We'll try some conservative measures. But ultimately, at some point, we need some scans to figure out where the entity is. And, you know, obviously, the most common one is an MRI scan. Some people hate MRI scans. Some people love them. They're very claustrophobic. You know, whenever I've needed an MRI scan, I try to be post-call, so I fall asleep. You know, different entities to that. But that is, you know, but in the world of pacemakers or in the world of patients with aneurysm clips, that may not be necessarily the modality that we need to make that diagnosis. There are other modalities. We could utilize myelograms, CAT scans, and that's, again, going back to creating that patient-centric treatment modality. And what is radiculopathy? A lot of us have heard that. Radiculopathy just means an inflammation or irritation of the nerve. It could be for many different reasons, but we ultimately have to find that source. So again, we kind of went through this anatomy. On the left is a normal anatomy. That's called an axial cut, meaning we're being cut this way through the neck as you go up. On the right is one with a disc herniation, and you could see it pushing on that nerve. And of course, as in any cartoon, you have to change colors if there's irritation. So the nerve is a little bit red over there, meaning that it's being compressed. So surgery. Well, again, I'm going to reiterate this. I'm a very conservative surgeon, and I try to avoid it. But what do we do first? I believe in prehab. And what does prehab mean? Well, we all know what rehab means, right? Because what does rehab mean? It means that you've had something done and then you got to go get it fixed so you can come back to your normal activity level. But what if but if I told you to go run a marathon tomorrow, are you just going to run for the marathon? No, what's the first thing you're going to do? You're going to train, right? And surgery, I treat that as a marathon. So you got to train for surgery. For two reasons. One is if you get well from the prehab, then kudos to you, you don't need surgery, right? So we all high-five each other, and I tell all my patients, the ones that get better with conservative management, you're going to do the hard work, I'm taking all the credit. So that just because I don't operate on you doesn't mean I don't take the credit for you getting better. But with prehab, it also makes you stronger, right? Because the stronger you are, the better you'll do after surgery. My expectation of all my patients is to be walking within 8 hours of surgery. You know, patients are like, well, how long will I be down? How long will I be bedbound? You're not. Because surgery, even though there is discomfort and we treat it, our goal is to get you back on your feet to normal everyday activities. It's like going to the gym after you haven't worked out for a long time. You're going to be sore afterwards. And I'm not saying that you're going to be walking miles post-op day one, right? But what do I want you doing? I just want you little walks, little steps, just to get that blood flowing, just to remind your body, hey, I feel good, okay? Now, if you've failed conservative management, and we have lots of modalities. We do prehab, physical therapy. We do injections. We go to our colleagues, our chiropractors, you know, with the right appropriate. So all these things will be prescribed first. If they don't, and you're still there, and we call that failed conservative management, that's fine. That doesn't mean that you failed anything. It just means you may need to go to the next step. And you go from the least invasive, which is physical therapy, you know, maybe a TENS unit, to a little more, which might be an injection, to possibly surgery if you need it. And that's how you kind of have to think of the protocol that, you know, if you come to us, that's our protocol. But if you go somewhere else, and no shame in that, at least you'll be armed with the information, you know, that should be the protocol that should be approached with spine surgery. The problem with spine surgery, as you all know, is everyone's terrified to go to a surgeon because they assume the first thing that they're going to get is offered surgery. And that is true in some places, but not our belief and our philosophy. So there are many different types of spine surgeries, right? But here we're just going to focus on the motion preservation. And let's start with the neck. In the neck, you have different types of surgeries, right? You could have a fusion, which is what a lot of people, and I'm not including like the laminectomies and all that. I'm kind of hyper-focusing this talk. You could have the fusions, right? And a fusion means you put some sort of a spacer with a plate or screws and keep it from moving, and that helps with the arthritic pain. Or you could have an artificial disc, and this came out, you know, in the last couple of decades, and they've been improving throughout the years, and this is definitely a modality to treat patients, okay? So with the artificial disc, or you may hear disc arthroplasty, okay, what does that mean? So the goal of a fusion is to fuse or keep those two bones together. One of the complications of the fusion is that they don't fuse together, right? And that's called a pseudoarthrosis. The opposite is true for an artificial disc. The goal is for them not to fuse together and keep the motion preservation, okay? Sometimes the complication of a disc arthroplasty is the body just says, hey, don't want this motion, you still end up with a fusion. So that's kind of how I try to explain it to patients. Now, the reason I like motion preservation, and it's been going on for a long time with our European colleagues, and definitely going on a lot here, the reason I like it is you don't create another moment arm or a stress factor on the level above and below, okay? So that's why I think it's quite important, because then you try to, you know, going back to the degenerative disc disease, if you create the motion preservation at that particular level, you're not starting a degenerative process at the level above or at the level below. Does that make sense? The other thing is at times when you do a disc arthroplasty or an artificial disc, you could always do a fusion, but you can't undo a fusion, right? So those are always options. So both surgeries are pretty much identical. The only difference, so in both surgeries, the unhealthy disc is removed. You take the pressure off the nerves and the spinal cord. You give the nerves room to breathe again and the spinal cord room to breathe. The difference is what you leave as your footprint. In a fusion, the footprint is either another piece of bone with a plate or another cage. You'll hear all those, you know, bones, cages, plates, screws. In the arthroplasty or the disc, artificial disc, you're leaving, it looks similar to a cage, but the difference is it's got usually a plastic center that the body could still rotate and the joint could still rotate over. Okay? They definitely provide pain relief. Now, the trick is, you know, what I always teach residents or when I go to conferences is you have to understand who the right patient is for the right procedure. Just because you have a tool does not mean it's right for everyone. And my favorite quote is, a fool with a tool is still a fool, right? So you have to understand who the right, and you know, in terms of surgery, we're all trained and we're all trained surgeons. When I started practice, you know, I think like a decade ago, the toughest part for me wasn't surgery because I was well trained. It was deciding which patients. That is where the true art of surgery comes. Which patients need what procedure and if they need a procedure. And which one would benefit each patient to their fullest ability. Okay? So here's the difference side by side. On the left is a fusion, you know, with the plate screws. They're different modalities depending what company. Screws come in the rainbow of colors depending on who's providing them for them. And on the right is an artificial disc. And you could see there's the plastic material in the front and the two, you know, no pun intended, little spines that are connected to the spine that, you know, house that plastic component in the middle. You know, I tried to show this picture to my dad to invite me to Thanksgiving dinner. He still said no. So just you guys keeping count. So artificial disc, you know, when it came out, everything comes with a red label, right? You know, the FDA approved it for certain things. That being said, does that mean it's always the case? Not necessarily. But the FDA has done its job and says X, Y, and Z. And if you go outside the goalposts, you at least have to understand those warnings, okay? Ages is usually 21 to 60. I will say I won't go under 21. The reason being is it's not a skeletally mature individual. But over the age of 60, you could have a conversation depending, Dr. Bowers could talk to this, depends what your age is, just a number. There's 40-year-olds that have such deteriorated bodies. It could be an 80-year-old, but then there are 80-year-olds, I'll see them, I'm like, wow, you're 80, and then I look at their spine and they only have one level of arthritis. I'm like, it's different. So that's why, sometimes these numbers and, these, labels in the, on the products for FDA approval has some problems with it, right? But my goal here as a surgeon is to provide you that informed information to make, a smart decision for yourself and your family member. And what I tell patients is I encourage family members to come. The more questions, the better it is, because there are many studies that shows an individual goes to a physician, what happens? They only remember about 20 to 25% when they leave. So let's say you have two people there. Hopefully you'll remember, but it's different. It's human nature, right? Because what happens is you may ask me a question, and sometimes instead of, and this is human nature for any conversation, your next intuition is to think of the next question and not necessarily listen to the answer. That's why my wife says I'm horrible with names, because I'm like, hey, I'm Mark, and then, you kind of go on into your spiel, but that's important, right? So for something that's not emergent, I encourage, I try never to offer surgery on a first meeting a patient, because you need to really think about it, do your research, talk to other people. I encourage second, third opinions. A surgeon is no different than a marriage in the sense that you have to find the right person. And it doesn't mean one person's worse than the other. It just means that's the right person for you and to treat your etiology of your symptoms. Again, we talked about the disc. Obviously, C1, 2 does not have a disc. 2, 3, there really haven't been many studies. And realistically, at C2, 3, there's almost never, I never say never, I've always been corrected, true disc herniations and all, because of the less motion up there. So usually when I do a fusion at 2, 3, it's really because of a trauma. So really it's from C3 to C7. And, we talked about the arm pain, the weakness. I usually push mine from 6 weeks, even though the label says 6 weeks. I actually try to push patients for 2 to 3 months of conservative management. Because you never know, because just the inflammation from the initial injury could take 2 to 3 months just to heal, right? One other thing that I'm very specific about is, even if we decide to do surgery, on the day of surgery, I will ask you, are you still having the same pain? If you're getting better, about 1 to 3, 4 patients a year, I cancel the day of surgery because you're getting better. I can't get you any better than your own body gets you, right? For me, it's not about fixing a scan, because if I was about fixing a scan, I wouldn't even have time to do this talk, because I'd probably be doing 7,000 cases a year. right? But the key is to fix the symptoms that are aggravated, that are not helped, that match the scan. There are patients with horrific scans that have no symptoms. We just had a gentleman from Florida refer to us that he was offered a 3-level fusion, but he was completely asymptomatic. And I'm like, yeah, you could do it, but at least, there's the, when I was a fellow, the one thing I was taught, and Dr. Bowers could vouch for this, the worst thing you could happen is an unbusy surgeon, right? Because, so the key is, for me, I'd rather never do another case in my life. I try to do what's right, but none of us are perfect. But that's the whole caveat to this is if you're getting better, so be it. That doesn't mean some people may be cured for life. Some people come back, and we kind of see all of them. They may come back in 5 years. They may come back in 5 months. But the key is treat the symptoms, not a scan. And that kind of brings us to the specific images. We kind of discussed the disc herniations, the stenosis, the foraminal stenosis, the central, and this is where you kind of work together as a team. Now, who should not? Someone with a whole body infection or some sort of infection, unless the infection is what's causing the actual stenosis or the pressure, then you shouldn't have surgery at all. Even if you're thinking about a fusion, you got to cure the infection first. For better or for worse, being at a level 1 trauma center with arms and fingers all over Michigan, we do get a lot of these patients that do have infections, but that's for a different time and a different talk. But the key is you don't want to spread that infection to somewhere else in the body, okay? If you have an unstable spine, you got to make sure, but you also have to see how much instability there is. Because if there's too much instability, you may still need a fusion, or at least that should be discussed. Also, even though I may have a preference one direction or the other, I still offer all my patients both modalities, so they have the appropriate information. We talked about the arthritis. This will be determined, the disc may have begun to turn into bone. Sometimes if the bones are already fused together, doing motion preservation is not going to help, and it will defeat the purpose. So that's why you at least have to make sure that the joints have not fused together from an arthritic process already. So radiculopathy we kind of talked about. Could it be used? So now we're going to change the subject a little bit, and we're going to talk about the lumbar spine, or the lower back, right? You could actually do artificial discs in the lower back. They've been at it almost as long as the neck ones. With the lower back, a lot of them have not been improved by insurances over the last decade. There's been a turn recently. There is a time where I haven't done any of these. And now recently there's been a turn on the insurance companies because they realize the motion preservation is real and it does help patients. So now they're slowly kind of coming to reality and to the present treatment process. So I do those as well. Fewer than in the neck, but they are done. The key to it at this point is anterior means from the front. So you have to make sure that the pathology, which means the reason you're having your pain, could be reached from the front. Not just from the back. Because if you can't reach it from the front, or you can't create some sort of an indirect decompression, that defeats the whole purpose. Okay? So again, we talked about it. We talked about deteriorating disc. I like deterioration rather than degenerative disc disease because I think it's a better term, and I think it should be a better coined term. Okay? And in terms of radiculopathy, we kind of talked about it. It could be related to a disc bulge, as all of us here. And a lot of people are concerned about disc bulges, disc herniations, and what happens with those. Well, There have been plenty of studies that show that 30% of 30-year-olds, 40% of 40-year-olds, 50% of 50-year-olds, so on and so forth, will have some sort of a disc bulge or disc herniation on their scans. The problem is, as we advance and our scanning images advance, that doesn't mean they completely correlate to what needs to be done and mean you need a surgical intervention. So we get caught, like I mentioned earlier, on the terms that we see on our radiological reports rather than focusing on our symptoms. One of the important things that I discuss with all my patients is you never want to operate on a neck for a shoulder problem or on a shoulder for a neck problem. Same with a hip for a back problem or a back for a hip problem. That's why you need to work very closely with all your colleagues. We work very closely with our orthopedic colleagues. Okay? Sometimes it's just obvious, but sometimes there is a little bit of a gray area and we have to determine which direction. And sometimes you may have both problems. And then you have to decide which one's worse, which one's less worse, and which one do you think will bring you back to your normal life the quickest, because that might be the one that you may need to treat first. And we kind of talked about the foraminal stenosis, the difference between foraminal and central. Foraminal is the holes where the nerves come out, just to re-emphasize what we discussed earlier. And central is where the main dura and the sac is, which in the neck is spinal cord. And as you go down the spine, in the thoracic spine or the middle of your back, it's still spinal cord. But as you get down to the lumbar spine, it's mostly nerves and no spinal cord. Okay? So that's where the difference lies, and depending on what you see there, might be a different treatment modality. So I'm going to stop there, and then I was going to show you one or two cases, and then we could open it up. Anything pressing, or should I continue with these, and then we could open up the floor? Maybe I'll just finish these last two cases, and we'll open up the floor. So first one is a 34-year-old female with long-standing neck pain and radicular symptoms. Sorry, the scan kind of took it over there. So very nice young lady. Actually, coincidentally, one of the first patients I took care of at Hurley. And she came in with a disc bulge with pain going down her arms. She's tried everything for probably about 6 to 12 months. From injections, therapy, TENS unit. She's tried it all. And she got to a point where she's like, you know, what's next? So, like I told you guys at the beginning, I still will try to convince you out of surgery if it's non-emergent. And after a long discussion, after discussing both fusion and disc arthroplasty or artificial disc, that's what, bless you, that's what we decided to do. And we did an artificial disc. We just saw her, I think, for her 3-year follow-up, and she's doing well, you know, and that's what's important. Similar case, but this time in the lower back, lumbar spine. This gentleman is 42 years old. Lots of back pain and lumbar radiculopathy, meaning lumbar, meaning lower back, radiculopathy, the inflammation from the nerves in your lower back. Or the common term that everyone's heard or on TV, sciatica, right? Had a similar discussion with him. He was an athlete, does not in any way, shape, or form want a fusion because he's concerned about adjacent level disease. And adjacent level disease means the level above, which can happen over the course of your lifetime. So for him, again, we decided an artificial disc, and that's what we did for him. And he's doing remarkably well again. And like I said, because of insurance problems, and again, you know, we always try to do what's best for the patient, but at some point, if you need something. We just started doing these again, I want to say 2 years ago? Year and a half, 2 years ago, because at least the insurances are buying in. So when possible, and again, going back, it's got to be a multidisciplinary, patient-centric decision. We try to do motion preservation surgery. The multidisciplinary approach is probably the most important. You want as many colleagues in it, you know, as possible, right? And you also have to understand all available options prior to making an educated decision. Thank you so much for everyone's time.